This round of applause welcomes our guest. Welcome to you all also to the audience. This guest of GiovedìScienza Science on a Thursday is for a man that many people who are here tonight owe their life to. A lot of people are aware of the fact that Professor Salizzoni's work has saved many. His center of liver transplants is either the first or the second in Europe, so he is a pride and glory for our city and for GiovedìScienza. So the round of applause, in fact, shows that most people know, and those who didn't have received the material. I would just like to mention the fact that, first of all, many, many years ago, Professor Salizzoni came here, and it had been a very special GiovedìScienza because we had spoken about mini-invasive surgery, which at the time was a novelty. And since we had shown some rather crude films, one of the members of the audience had been overwhelmed. I don't think this will happen tonight, but I think that as soon as he saw it, Professor Salizzoni ran to the audience, then said it wasn't anything and came back. This type of reaction, I think, is the one that a surgeon has, especially a surgeon who does this type of work, and the transplants are very tiring too, because they're very, very long. As you see, the transplant starts in '63, but Professor Salizzoni will be talking about it with the person who was the master of all the surgeons, Star. Stars is maybe has a few problems now, but is still alive. Transplant for a liver transplant for a long time was experimental and very difficult, while now we know that thanks to the skills of the surgeons, it has become one of the safest transplants with a survival rate which is outstanding, extraordinary. But before beginning, I would like to ask Professor Salizzoni a question. That is to say, how do the fingers of your hand keep fit and trim? Because I've heard that if a surgeon stops operating, even for a short period of time, it's a bit as if he or she were to lose his or her skill. Very often, they don't regain the skill they had. I wouldn't word it like that. I think I think your head is what needs to be trained, because that's where the impulse is. And two hands that work well without a good head should be cut off. Well, it is true that as in any activity which goes from walking to surgery, the more you do, the better you can do it. But both in one field and in the other, you must certainly have your head. Well, we've taken the head for granted, but the other point is that you have to be available, and that is, there's no moment in which you can say, sorry, I can't. You always have to be on call if there's a liver that arrives and you want to transplant it. This was very true up to a certain point, to the end of the 90s. Then luckily, there is now a greater number of people, and the team itself one team must always be on call. There can be some things that change from 1 hour to the next. So you might be on a plane that takes off from Malta or Prague, I think, recently, about a year ago. In about half an hour, we were on a plane. In the meantime, the team has to be on call and ready. So let's talk about these 30 years of liver transplant. 30 years, 25 of which in Turin. Before that, I was in Brussels and Louvain, and before that, with the idea, since '81, I started going around to see what they were doing with liver transplant. Liver is an organ that attracts general surgeons because with the esophagus, it was considered the most difficult organ to operate on, the one which required the top skill, the top. It was the glory and satisfaction, yes. The people who were working on that was a real surgeon. This first slide, well, we're very, very young here. This dates about 25 years ago. And you can see that my hair is still dark, but roughly, technically, we were doing the same sort of things, and it was extremely tiring. But lots of things have changed since then, over the past. I think rather than from a technical point of view, in terms of what people think and do. For those who wish to understand, this is the diseased liver. When is it that you change the liver? Well, when it becomes something like this. This is a large node cirrhosis, and the patient who had a liver like this would not have survived more than 2 or 3 months had he not been transplanted. This gives you an idea of what it looks like. But then there are livers who look normal but then have to be transplanted, but that's a different ballgame, and I will be talking about it later. Here you see the evolution of liver transplantations in Europe. It basically took off in '84. You see how in '84 something very particular happened, which was not the surgical technique, which suddenly improved, because that existed since 1963 from the first transplants that were successful from a technical point of view. It's just that the patients couldn't survive because there was a problem of reject. We didn't have immune suppressors. That is to say, we didn't have cyclosporine, which, as we will be seeing in a moment, was made available for clinical use in '84. If anybody are interested, that's when I started. That's when I started working with transplantation. Before cyclosporine, well, at the same time, I would say. That's when I started. But when there were very few centers, there were 4 in Europe at the time, so activity was concentrated all in those 4 centers. Things had changed radically because you can see that these were the results. 31% survived at 10 years. That was something already, but not. That was 68 to 88. But things changed radically after. See what has happened in terms of survival. And I will be telling you what has happened in this period and what made it possible for us to have such good results. For those of you who are interested, this is the Turin activity. We've had even 166 in a year. That was 2005, if I'm not mistaken. A lot of activity, the very few of us, and that year really we burnt out a bit. We all aged a bit, but then in the few years that followed we recovered, although we have also added other types of surgery, as well as a deliberate return to the esophagus surgery, which is the other one which requires time, skill, and knowledge. This is the shopping list, so to speak. These are transplants that were done in Turin. Here we have 2,737, or it was between September and now we've had another 30, of which 126 split, that is to say, livers that are split between two, or liver and kidney, liver and pancreas, and then the lung obviously requires a lung surgeon, Professor Rinaldi here in Turin, and then we see what the domino transplant is, and transplant from a living donor. Split comes from the English split, divide. It's like a banana split. You divide it into, because from this point of view, the liver is an extraordinary organ. Yes, you can split it in two, and it'll regenerate. We'll see it in a moment. There will be images to show you. I have also avoided movies or film clips, but here you can see slides. Here you can see the first few years in between and now. The green one means that at 10 years, about just under 80% of all patients survive. People who would have died 10 years before, but 10 years later, they're there, they're healthy, some are in full working activity, or even sports people. And children, well, with children, they have normal life expectation. In this respect, I would like to recall that one of our first transplanted little girls have become mothers, which means that the people who have been transplanted are no different from anyone else. The evolution happened through revolutions from a medical point of view. Clearly, the technical surgical point of view, although it's possibly not the most important part, and then drug treatment, the development of the hepatocarcinoma transplantability criteria, and the development of the criteria to accept donors and to match donor and receiver. For example, in the past, we used to think that a 50-year-old donor was too old, but now, in fact, we use them, even for children's transplants. From a technical point of view, here you can see the first transplants. We used a pump and it was extracorporeal circulation. It was extremely complicated and very long, because to close it then, where the tuyo, as we then called it, was inserted, it took us about an hour and a half. And then the learning curve improved. So, as in all things, we started to do without a few things. We introduced others. For example, this is a liver which still has to be transplanted. It has been harvested and it is perfused, reconditioned within a certain device, which gets it to start up even before it is transplanted into the receiver. In the meantime, the liver can improve its performance. The transplant has become much simpler. You can see we've eliminated all the various tubes and pipes. It's attached to a vena cava as if it were a bag, it's piggyback. There isn't an anastomosis of the lower cava. It's simpler from a technical point of view, but this in itself hasn't made the surgery simpler. Swifter, certainly, because to do this, you must know how to. And luckily, in our group, there are several people, at least 5 or 6, who know how to do it. The other big revolution, the first revolution, is that of immune suppression. When we started to transplant there in the 50s at the top of the pyramid, you used to irradiate the transplanted organ. Then AZA, Imuran, which is a steroid, was used with a steroid. This is still fashionable. It's also used in sports doping, but I always make this joke because, as you know, I was also this was one of my fields of interest, to reach this very long line in 2015. This means that these are immune suppressor drugs. There are lots of them now, so there are many more options to be able to fight reject. Reject is no longer the scarecrow that it used to be in general. In transplants, and specifically for liver transplants. I mentioned cyclosporine earlier on. Cyclosporine was isolated from here you can see Tolypocladium inflatum, a Norwegian fungus, and it was introduced in 1984 as a drug, which is where, in fact, a transplant took off. This immune suppressor drug has two major advantages. One, that it's dose-dependent, which means it can be modulated and can be dosed in the blood, so we understand whether you've overdosed or underdosed. And with this, clearly, we've obtained extraordinary improvements in terms of the reject, which have had an impact on the results of survival. And however, there is a disadvantage that if you overdose, infections increase because the person is immune suppressed. Don't think that I am a genius in terms of immunology, but if we would like to outline it, here you can see this is the cell which has antigens. This is a lymphocyte. Clearly, the lymphocyte, when it has when it sees receiving an antigen, it activates, it tries to block it, but with immune suppressors, we manage to close all the inlet, which means that the activation of the lymphocyte is blocked, and therefore there is no reject. As well as immune suppression, many other things have changed. I increasingly realize after many years that when I began, and with me many other youngsters who are no longer youngsters now, we began our activity, but this was also true for our teachers who were very knowledgeable but didn't know everything like we didn't know a lot of things. We didn't know lots of things. We learnt things in practice. We knew how to use our hands and brain, but we failed to know lots of things or didn't know it. For example, we knew about hepatitis B that there was antigen Australia, but the anti-HCV Delta virus and so on, well, all about all that we knew very little. Basically, here you can see the sequence of the transplants for hepatitis B, and a large number of the cirrhosis were discovered to be due to, well, the cause of many transplants was due to hepatitis B, which was something we knew very little about at the time. The first experience, the early ones of transplants for hepatitis B, gave very bad results. Why? Well, because we couldn't fight the virus. But when we developed immunoglobulin for anti-hepatitis B, the HBIG, that were extracted from the plasma of the patients who had produced it and then injected, we began to be able to control relapses of hepatitis B. Then we developed antivirals, which was safe. Where did they come from? From a study that was carried out for another disease, which is coming back, which is HIV. So antivirals, which were progressively discovered to fight HIV, were then tested and were also very effective for hepatitis B. I remember in 95, 96, when in an illegal manner, we can say it, because people have retired and many years have passed. We have the statute of limitations. We used to go from the Maria Vittoria Hospital, and we used to take the treatment of the HIV patients, or patients who died of AIDS, 3 from here, 2 from there, and then they were given outside protocol to patients who had to receive transplantations for hepatitis B. There would be quite a few funny stories and some are interesting stories. I remember a very young patient with the hepatitis B who was a young director, and he wanted that his transplantation was filmed. Unfortunately, he had a very early relapse and died very soon after. And before dying, he wrote his story. Immediately after, things changed, just as they are changing for the other virus, which we will see. Viruses are fought before the transplant, during and after. Why during? Well, because while we harvest the liver, clearly we eliminate it, but a lot of the viruses stay around. So we have to fight it. It's much easier, though, to fight the remaining viruses during the transplant. Here you see the development of transplant following hepatitis B. These are the years. The treatment has now been consolidated. And now you don't even have a IV, but an IM injection, an intramuscular one. Survival indicates what I've just said, because from some point onwards, when we introduced antivirals and we started to transplant, post-hepatitis B transplants, we see that we get very good results. While till a year ago, hepatitis C patients were in a very bad situation. See the difference of survival between people who have cirrhosis post-hepatitis C and post-hepatitis B. And probably there are also the others here you can see, which still exists, alcohol cirrhosis, although they're anything but the majority, and also they're certainly not the majority. And so there is a bit of a myth that says that alcoholics should be hidden in the attic because people were ashamed of them. If the person used to say has cirrhosis because they've been drinking, it is true, but when in 85, 86, 87, well, until 1990, until we didn't know what hepatitis C was, we used to call it non-A, non-B, we tried to get people to confess, and there were some gentlemen or ladies who said who had cirrhosis, and we didn't know where it came from, and we convinced them that in fact they were drinkers, and in the end they used to say, yes, I've been drinking from morning to night, in spite of the fact that maybe they've never drunk half a glass in their life. This makes you think, first of all, on our certainties that sometimes are too certain, and not only in the medical field, and we can see what is happening in the world. When you're too certain that things are in one way, you have to think things over. And in particular, think that possibly we don't know, because either we haven't studied or some things are not yet known. And this is exactly what happened for hepatitis C.
Graft dell'epatite B. Allora, arriviamo alla nostra epatite.
Let's go now on to hepatitis C. I've already told you a few things, and what you can see here is the sequence, the percentages, and you will observe that most of transplant cirrhosis are post-hepatitis C infections. This, for a long time, kept those rather bad outcomes, as you can see here. Still good, because it meant after 10 years, 50% of the patients were still alive. But patients who would have died otherwise, but compared to the other results, they weren't particularly good, not satisfactory. Why? Well, because the virus of hepatitis C reinfected the transplanted organ in 100% of the cases. In some cases, it was subclinical, while in some cases, very rare, it then responded to the treatment, which was the one with interferon and ribavirin. But in most cases, unfortunately, the transplanted liver was attacked by the virus and again developed cirrhosis. So the eradication of the virus was the main aim that we wanted to attain. And until about a year and a half ago, 2 years ago, every time we started transplanted a virus, used to go to the operating theater. We said, well, we've got to do this, but we know that most of our work will be useless because 50% of these patients have a very severe relapse. In the past year, here you can see these colors, which brighten the picture, because, in fact, the world has changed completely. Not by miracle, nor suddenly, because we were all waiting for it, because we knew that those who could were testing thousands and millions of samples to find the right combination, to find the right antiviral that would work against hepatitis C. And this was done it was very expensive, billions and billions. It was a US multinational that found the first drug, antiviral drug. And it's a very simple thing. It's like taking an aspirin every morning for 30 days. You take this, it's not an aspirin, but the drug for 30 days, and then after 30 days, the virus has gone. Or at least it is no longer active and it doesn't do anything. In practice, it's dead. The first one is sofosbuvir. Then there have been others by names that you can't really read here. Each one is specific for a given condition because, as you know, for those of you who do know, but otherwise I'm telling you, the virus, virus C, is not unique. They're not all the same. There are various genotypes, so there are some that answer better one drug and another one better another drug. In any case, all the genotypes are well covered, so much so that the result that we get with these treatments, this revolutionary treatment, is virtually close to 100%. This is what I'm showing you, cirrhosis, donor liver transplanted, recipient with HCV recurrence or relapse. Thanks to the new antiviral treatment, we have solved partly the problem. First of all, we give the patient a treatment before the transplant, and then after, to avoid a recurrence. This is very important, also because it has changed the type of donors, as I will be explaining in a few minutes. This is the treatment, the antiviral treatment. It has to last at least 30 days. Otherwise, it probably won't work. This here is a graph that we've been plotting. In fact, we've been using the treatment for about a year. And with the new treatment, you see that in the first year, there is a drop, first of all, because when we were euphoric, we transplanted patients who were too advanced, which means that they had early disease not due to the virus, but to problems of other nature, infections, hemorrhages, or problems like them. In any case, non-viral ones. This could remain very, very straight and to be comparable to the B1, which means in 10 years, those of you who will be transplanted for a C hepatitis will have a probability of survival at 10 years, which is close to 80%. Here again, I think we have to give a few explanations. 10 years are not a lot. Well, first of all, let us start to think that if you transplant at 66 and 67, it's already 77, 78. But things don't finish at 10. We have examples who I can see one person sitting here who's also skier, and between one reject and the other one, in spite of hepatitis C, managed to kill the virus, listening to all of this 30 years down the line. Hepatocarcinoma is the other big problem, because everybody thinks that you should transplant when there is a cancer and others don't, and I think things have to be seen the other way around. That is to say, you have to understand when it's best and when it's not a good idea. Initially, we transplanted tumors that were 10, 20 centimeters. In fact, tumors were so developed that it recurred, even though there had been a transplant. In 1991 in Pittsburgh, they started to see that those who were transplanted and were accidentally, they found an ACC, a hepatocarcinoma. That means that they were transplanted for cirrhosis, but they found a hepatocarcinoma had very good results. So the problem was up to what stage you could transplant and have success. The Milan criteria emerged. The tumor had to be not too developed, up to 3 nodes. Each node should not exceed 3 centimeters. We've gone beyond it, but then at one point, possibly we overdid it, because again, we exceeded the Milan and Paris criteria and overdid it. And clearly, the longer the journey, the more expensive the ticket. They're the worst results. While if you stay within the Milan criteria or the Paris ones, results are more than satisfactory. It's called the metro ticket paradigm, and I wanted to present it to you because I think it's very interesting. Basically, if you respect or abide by the correct parameters of the transplant, results are more, for HCC, results are very satisfactory. All I have said so far, when I said it changed our approach, changed it also in how we considered the donor's liver. Initially, we thought a 50-year-old was old. Now we've changed this. These are the classical criteria, blood group, size, and age, which were used or abided by up to a certain point. Although this also included the fact that patients could be transplanted with another group in the case of emergency, as I was saying, blood group 0 with a group A and so forth. But principles of fairness and effectiveness for a resource that is insufficient started to weigh. So we also identified them, and they prevailed. Urgencies and severeness, as well as the aforementioned criteria, has become one of the criteria. But how can we understand whether somebody is severe or not? This acronym MELD, which is Model for End-Stage Liver Disease Score, is based on an algorithm which is calculated. You can use an iPhone for it or a computer. There are 3 parameters which are objective, which are creatinine, bilirubin, and INR, that is to say, coagulation. There may be cases in which there are scenes that are not pleasant. For example, the patient comes who, for example, has ascites with legs that are also swollen, but maybe he's had an hemorrhage, or she has had an hemorrhage a few weeks before from the esophageal. He is convinced that he is the most very severe case, but our iPhone calculated and says, no, sorry, if we use this algorithm, your MELD is 12. Your liver is going to be working quite well. The other one looks at you and says, maybe you're completely mad, you start craving mad. Vice versa, there may be a patient who apparently is in good shape and possibly even athletic, and he's changed color. Relatives say yellowish. Maybe it's bilirubin, but kidney's okay. But you go to see the NR 1.5, 1.6, and the person says, should I be transplanted? We calculated your MELD exceeds 17, 18. We better transplant you very, very quick, because your life expectancy on the basis of this is a year and a half or less. The criteria that used in the past were partly subjective, because we considered the ascites, because the severeness of the esophageal or encephalopathy, which could be considered very important, while another surgeon might put it with a lower score. But they were subjective, and when there are individual elements of judgment, it is easy also to make a mistake. You might make a mistake deliberately or involuntary, but in any case, it's possible to make a mistake. It's possibly that patient with an ascites might be considered urgent, because there might be other parameters, because possibly also his size or her size. This is particularly true for polycystic patients, for example, livers that weigh 14 kilos. It makes it impossible to live. All these things should be ethically and objectively assessed. Let's go on. Very simply, these are donors in Italy. Donors, you can see that in Italy there are about 1,000 transplants a year, 150 in Turin. Turin, as you can see, is one of the top cities. This is what has happened since '94. Very important numbers, because as well as numbers, it's also quality, and I would like to stress this. And here, now we have the other point, which is revolutionary. See what happens where the age of our donors is listed. In practice, about 40% of the donors that are used in Turin, it's over 70. We'd never have imagined that in the past, and maybe that will make us think more carefully, a little more in depth. In Europe, it is also considered, but in Europe is measured from over 60s. In Italy, a 60-year-old is virtually a youngster. And very often, it has happened that a 60-year-old's liver was split. To simplify this, Paolino Strignano, who works with me, prepared this slide where you can see that in our cases, there are 49 patients who are living with a liver who's over 90. There's one patient who's living with a liver that's 100 years old. What does this mean to explain what a median, a minimum, a maximum? If I transplant, as has happened, a person who is 60, 65-year-old, clearly I'm not going to giving a 90-year-old liver to somebody who's 20. It's very impersonal, but that's the way it is. But I will give it to somebody who's 65. 10 years later, if this person is alive, you're living with a liver that is 101. And thereafter, we took off because we're thinking, as somebody says, that liver is virtually immortal. It's not exactly like that, but it is true that it is a lasting organ. Who could say whether this liver possibly dying as late as possible, the one donor of cerebral death, and still having a functioning liver? Who says it can't be reused? In theory, it's absolutely possible. Why? Well, because liver has a big advantage compared to the other one. That is to say, the cells renew, the virus might attack it, the drugs might attack it, but if it's not extended in time for a long time, and therefore the structure of the liver is not altered, the cells are as good as new, which is why we see some livers that are 80, 90 years old that are perfect, because we do the usual thing. Why do we go to the students, for example, we say, how old do you think this liver is? Probably 20, 30. No, that's wrong. It's 85. No, says the student. It's the pantomime that every now and again we have fun in playing with our students. But going on with the things that we were using before, not only did we do this, we also use livers that are HBV positive or carriers. If I transplant a liver which is HBV positive, I can do that if it hasn't yet developed and then treat it. And the same with hepatitis C. I can take the liver of a patient who possibly didn't know but has hepatitis C and has carried it for many years, but if the hepatitis C has not caused any damage, and I can then transplant it into a patient, and I know that I can then fight it with the new antivirals. And in fact, it might happen that an HCV positive donor can be grafted on, I mean the liver of them can be grafted on, and because I know that those little tablets are going to get rid of the virus. I'm not going to talk about the domino one because we're going on for too long, and let's go on to the split. This is the image which is the most direct one, which can tell us how part of the liver, the left lobe of an adult, can be used and transplanted into a child. This happens also with children who are 3, 4 months old. And we divide it according to the lines of the anatomy. Here you can see a certain number of transplants are carried out in Italy with split livers. So it's not anything that is out of the ordinary. It's done quite often. So you split it, and splitting is a way of increasing donors, or seeing that with one liver that you harvest, you have at least 2 recipients, 1 adult, 1 child. The increase in the number of donors since an organ is such a precious and rare gift, we also try to work to increase donors, living donors. For example, we have applied this technique in 14 cases, mostly in 3 cases from the mother or father to give the left lobe to a child, while in other cases the right side of the liver to give it to an adult. But fortunately, the donations, that is one of the most virtuous in Italy, has made it possible for us to discontinue this technique, which is very interesting from a surgical point of view. You see here it's divided according to very specific lines, very slowly. It mustn't bleed, but it's a technique which unfortunately also has risks for the donor. With this is a split. This is transplanted split. You can see the left part untransplanted. Here you can see an adult hand on a child, which gives you an idea of proportions. Another big novelty, which is a donor and with a cardiac death. We know that all donors have had cerebral death. We know that when the brain doesn't work anymore because it's cerebral death and it can't give any impulses, everything stops. Breathing and then the heart. But if a machine replaces the brain and pumps artificially, which means that lung and heart work, all the organs, except for the brain, continue to work, which means that you can donate from someone who has had cerebral death. But death can happen in another way, which is to say that you may have cardiac arrest. If you have cardiac arrest for whatever reason, but when the heart stops, the first thing that dies is the brain. The other organs are for a certain number of time, certain amount of time, although it's called warm ischemia, they are still alive in other European countries, but this is not possible in Italy, or it's not possible to do it effectively. People are used, if they say somebody who's in resuscitation has cardiac arrest doesn't have to last 20 minutes as in Italy, and in those 20 minutes you can harvest the organs with a shorter time of ischemia before it's possible. Kidney is also transplanted successfully. They are both transplanted successfully. With the liver, success is not so guaranteed. You haven't got the same level of success that is observed from cadaver harvesting, but it's still quite good. So in patients who are particularly severe, you can use these transplant donor, because survival benefit-based deceased donor liver allocation is something we're studying within a few months or week. So there are possibilities. It's not the same possibility or the same good results from the recipient of a liver which is harvested with a cerebral death, but in any case there are possibilities that otherwise you wouldn't have had. And I would like to conclude here, because I think the time is up. Pediatric transplant, just like to give you a few figures for Turin. Here they are, 63 whole, 49 split, and 15 reduced. There are complications. These are the various diseases which children may have, which require to proceed with transplant. And you see, the survival rate is very good, extraordinary. Basically, only 2 children did not survive. We've only lost 2 children out of 138 transplant, and I think this is an extraordinary result, especially if we see what the children looked like before and a year later. That's what I had to say to you. Thank you.
Professor Salizzoni,
before we came up on the stage, you told me that you started with the children's transplants. Yes, because the Louvain Catholic University Centre, the French-speaking side of it, had Professor Otek, who was and is our master in children's transplants, so we mainly transplanted children. I recall with a bit of sadness, but also with a bit of fear, 1988, when Professor Otte and I was an assistant, I made some, but in any case, I was the one who harvested. We managed to do 120 transplants with 60 children. The harvesting is very complex, isn't it? Yes. It's not anyone who can do it. You must be very good surgeons. I still say that it's one of the best surgical schools that there is. And we have, luckily, a lot of young people who are very, very good at it, and much better than I could, and I haven't been doing any for a long time.
Grazie tantissimo, Professor Salizzoni.
I would like to thank Professor Salizzoni very much. It was very interesting listening to him. And we greatly appreciated the way in which he explained things in a clear, straightforward manner, because it's difficult to understand and even more difficult to perform. Thank you.
Allora